Hello, everybody. My name is Professor Fiona McNicholas. I'm a child and adolescent psychiatrist, and I work in the Children's Hospital Ireland group at Crumlin. I also work in community child and adolescent mental health services at Lucina St. John of God organisation, and I work in University College Dublin. This is a pre-recording, and I know it will be available for parents and other individuals or clinicians who might find it helpful. And it has been organised by Cycle Against Suicide. It's part of a series of webinars or videos that are available to you. And this particular talk is talking about self-harm, suicidal ideation, and suicide in children and young adolescents. Just to give you a brief overview of how I hope to go about this video, I will start by talking about the definitions of self-harm, non-suicidal self-injury, and suicide, and move on to talk about the rates of suicide and self-harm, as this can often be confusing to parents and quite concerning. I will then end the session by talking about what clinicians look out for, what parents can do, and how to keep both yourself and your loved ones safe. The definition of suicide is typically considered the action of killing oneself intentionally, whilst that of self-harm is an act with a non-fatal outcome, where an individual initiates a behaviour with the intention to cause self-harm, or where they ingest a substance in excess of the generally recognisable dose. The intended outcome of this self-harm may or may not be linked with the wish to end their life. They may or they may not know the reason why they have engaged in the self-harm. And more often than not, it is seen as a coping strategy, albeit a maladaptive one. The term non-suicidal self-injury is often used to describe self-harm that occurs in the absence of any intent by the individual to end their life. And on many occasions, non-suicidal self-injury may be considered cutting, banging one's head, or engaging in other such behaviours. Whereas suicidal ideation is when a young person has a thought or a plan about wanting to end their life. It may be active, in which case they are beginning to seek out methods to do so, or it may be more passive, such as an idea that I wish I went to bed and I didn't wake up in the morning, or that my life is so difficult at the moment, it wouldn't bother me if I got knocked down by a car. The different terminology and definitions that are used by different clinicians and by different researchers is one of the biggest difficulties in trying to ascertain what the exact rates are of self-harm and indeed suicide amongst the population. I'd start off by talking about suicide rates because this is something that is very concerning and alarming to parents when their young child may be engaging in self-harm. So whilst the definition might initially seem rather straightforward, that isn't always the case, because suicide statistics come from a declaration by the coroner. When there is an unexpected death, the police or clinicians will refer the case to the coroner's court, and the coroner will make an adjudication, sometimes based on collecting additional evidence, as to whether the individual deliberately ended their own life. Hence, a definition of suicide or a conclusion of suicide will be made. There are possible errors in the determination, and sometimes whilst an outcome is made, maybe more information comes to light sometime later, and the coroner will actually reverse that decision. Hence, from year to year, statistics on suicides may even change. There is a time delay from when the person has died to the declaration by the coroner. Globally, however, there has been a very welcome reduction in suicide rates amongst all ages. In some countries, this is much more apparent than in others, And one of the leading countries is China, where over the time period studied between 2009 and 2018, there had been a reduction of reported suicides by 64%. India is also another country where there has been significantly large reductions. And part of that has been felt to result from more urbanization and more improvement in access to medical care, particularly when individuals have self-harmed by overdose. However, the same cannot be said about rates in United States of America, and over the time period studied, the rates have actually increased. Now, it may be of note that one of the highest rates of death by suicide in America is due to the availability of firearms. And this is a contested issue amongst many states in America, where there still are resisting additional legislation with regard to the ability to carry firearms and to have them in the home. Moving specifically to the statistics of suicide in Ireland, over this time period studied, there has been a 38% reduction in rates of suicide. And in the age group that you might be interested in of our young adolescents, the age group 10 to 19, this decreased by 31%. So looking at the global burden of diseases, they looked at self-harm rates and suicide rates over a 27-year period. And they involved 195 countries. And this extended the period that I have just mentioned up to 2021. All deaths have decreased by only 1.5% because the actual numbers of suicides have actually increased due to population growth. But what is important is the age standardized mortality rate has decreased worldwide. Up to 2021, this has decreased by almost 33%. It is felt to be due predominantly by means restricting, making it difficult to access certain poisons, making it difficult to access large quantities of paracetamol, getting rid of poisonous gases and fumes. The decline has been more notable amongst males than amongst females in all age groups, except in the 15 to 19-year-old age group. And the decline in females has been more noticeable than in males. There has been a 49% decline in female suicides compared to 24% in suicide amongst males. And you can see there from the graph that the decline has been more evident in some countries, more so than in others. For example, countries such as Spain, France, and Finland seem to have suggested the most steep decline. In Ireland, the Central Statistic Office documents our suicide rates. And the latest report that has been published was in 2024, and this relates to data collected in 2021. So you can see there will always be a delay in what is reported and the years that are covered. And this is, as I mentioned, on account of the coroner needing to adjudicate on statistics. And occasionally even data reported in 2024 may be revised in a subsequent report. So in 2021, there were over 500 deaths by suicide. And this is largely unchanged from the numbers in 2017. 80% of them were amongst males, and that's consistent with previous trends. The age group with the highest number of deaths occurred in middle ages, from 55 to 59, and 13% of all deaths by suicide were in those aged over 65. So looking at the crude rate per 100,000 population, the male age is 50 to 54, the rate is 29.5, and amongst similar aged females, the rate is 9.2. Dublin City was the local authority with the highest number. It's also the most populous. This just gives you a graphic illustration of the rates of suicide over the years, with the suggestion that there has been some slight decline, and also gives you the idea that it's in the middle age group that has the highest number of suicides. However, suicide at any age, at any time, is a significant concern. The rate in youth relative to the total rate, which is 10 per 100,000, is less, at 8 per 100,000. And fortunately, in the under 14-year-olds, is very, very rare indeed. That compares with the higher rate, almost double, 50 to 59-year-olds, where the rate is 19 per 100,000, double the overall total rate. So suicide makes up a large percentage of the deaths in young people, although not many deaths occur in this age group. As a percentage, it is quite significant. We do not expect young people to die. Between the ages of 20 and 24, amongst men, there were 98 deaths in 2021 in total, and 38% of them were due to suicide. That meant that for that age cohort, suicide was the leading cause of death. In a similar aged group of women, 35% of all deaths in that group were due to suicide, making it the third leading cause of death amongst women. Putting that in a context with regard to road traffic deaths, there are far fewer road traffic fatalities. There were 136 in 2021 from 123 separate road collisions. And again, although there are more male, it is not as extreme as with suicide. And the fatalities, more of them occur in the slightly younger age group. So now I'm going to move on to the rates of self-harm. Although the rates of suicide have been declining, and fortunately, even though tragic, they are relatively rare, the same cannot be said about rates of self-harm, particularly in the adolescent population. I'm going to start by talking about rates in the United States of America because they probably offer the best data. Every 2 years, they collect data from a significant number of children attending high school. And these are the questions they ask. Whether the young person has had persistent feelings of sadness or hopelessness that affect their daily activity. And in the last month, whether they have perceived they have had poor mental health. They ask specific questions regarding self-harm, and they use the terminology suicidal thoughts and behavior. They ask whether they have seriously considered suicide, whether the young person has made a suicide plan or attempted a suicide act, or whether the young person was medically treated for a suicide attempt. And since 2011, when they have been conducting this study on a biannual basis, nearly all the indicators of poor mental health and self-harming behavior have increased. So the experience of persistent feelings of sadness and hopelessness, which we would equate in part to depression, that has increased from first recording in 2011 to from 28% to 42%, nearly 1 in 2. And it is acknowledged that that was during the COVID time, it particularly increased. In the most recent survey, when they asked whether young people had experienced poor mental health, nearly a third answered affirmatively, 29%. 16% in 2011 had seriously considered attempting suicide, and this rose to 22% by 2021. 18% had made a plan, and 10% had attempted suicide in 2021 data. But only a small minority actually received medical help related to their suicide act. The latest data is now available amongst American youth for 2023. And you can see that seriously considering attempting suicide has increased to 1 in 5, making a plan 16%, and 9% attempted suicide one or more times. Surprisingly, the number that had received psychological or medical attention had reduced to 2%. This does not equate with the fact that their attempt was less fatal, but either they disclosed it less frequently or they were not able to access medical care for their behaviour. In Ireland, we have the National Self-Harm Registry, and this was the first registry worldwide that was set up in 2000. Every year, it collects data from all the emergency departments with regard to presentations with self-harm. From 2006, it included the pediatric emergency departments. They include presentations either with self-harm or presentations who came because of suicidal ideation alone, but without any self-harm. And nearly all the emergency departments give data to this register, making it very representative of the country. So 27 of the 29 emergency departments. The total rate of self-harm for the most recent data in 2021 was almost 13,000 presentations to the ED, involving nearly 10,000 individuals. So you can see that some people present more than once, 25% repetition rate. Typically, they present outside normal working hours, and the most common method of presentation is having self-harmed by overdose. 1 in every 510 people were estimated to have presented to the ED in such a fashion. If we look at the trends of self-harm presentation, we can see that the rates have increased over the years. 21% increase from 2019. They decreased, however, for males. If we look at the female rate per 100,000 population, we can see that amongst young girls aged 15 to 19, 880 present per 100,000, or 1 in every 113 females. The rate for males is less frequent at 1 in every 258. And rates are lower in children aged 10 to 14. However, that rate has increased significantly over time periods studied. So what you can see here is the rate of self-harm is far more prevalent among females than it is males, whereas the reverse is true for suicide. It is far more common among men than among women. However, self-harm is often hidden. And so studies have looked at what is the community rate of self-harm that does not present to emergency departments. And the ratio between completed suicide, hospital presentation of self-harm, and community self-harm was calculated in one region in south of Ireland. And this allowed the researchers to determine that within the young male population, this is adolescents, that for every suicide, there are 16 presentations to the emergency department with self-harm. But there is almost 150 presentations in the community. Some may be attending mental health or primary care counselling services, and others have not revealed the self-harm to anyone. With girls, for every death by suicide amongst a female adolescent, there are 162 cases that present to the emergency department, and over 3,000 cases of girls engaging in self-harm in the community. The common methods of self-harm, they're listed there before you. Cutting, overdose being most frequent, but also involving burning, punching oneself or the wall, scratching, pulling hair or eyelashes out, banging your head or throwing your body against something, inhaling, ingesting harmful substances, attempted suffocation or strangulation. And other methods of self-injury may be considered in some criteria of self-harm. These include substance abuse, eating disorder, or risky behavior where the person disregards their own personal safety. For example, having multiple sexual partners or having poor, abusive relationships. It's important when reading statistics or when reading the research that you understand what the definition is that the clinicians or researchers or policymakers are talking about. So in terms of what, when, and where, a European study, which included Ireland, asked what type of self-harm typically is occurring in the community. And this is typically cutting. It is not usually linked with the ingestion of alcohol or illegal drugs. And that's in contrast to the most common method in the self-harm registry, which is overdose, probably because overdoses are more likely to seek out medical attention on account of medical sequelae. Most self-harming occurs at home, and most of it is impulsive, occurring within the last hour that the person had thought about harming themselves. That makes it very difficult to interrupt, and therefore it is recognized that part of the treatment and management of self-harm is to recognize that self-harm may continue to occur, but that does not mean that you are still engaging the young person and helping them reduce the frequency or the intensity of their self-harming behavior. And part of the treatment focus will be moving backwards and trying to identify what the triggers are to the thought of self-harm, as opposed to trying to stop the act in itself. Again, there has been many studies done, and this accords with what we find in our clinical services when we meet young people who've engaged in self-harm, and we try and help them understand what was the reason that they engaged in that particular act of self-harm. And this can differ from time to time. The most common reason mentioned by the young adolescents in research that has been conducted, and again, this is internationally, is to get relief from a terrible state of mind. The second most common reason is they wanted to end their life. And the third reason was to punish themselves. I will just read you out some quotes that might bring it more to life in terms of what some of these meanings for them were. In terms of relief, one young person said, "I think it's somewhat of a release when you do it. You know, you're not really dealt with your feelings properly, but you have dealt with them in a way that's possibly the only way you can see at the time." Another young person stated, "When things were happening to me that I had no control over, I started hurting myself. This was something that I could control. I could do as much or as little damage as I wanted. It only involved myself, and I could care for the wound afterwards." Other individuals engage in self-harm for self-punishment. I would say that there's a definite punishment element involved in my self-harm, a feeling that I have to take things out of myself, to drive the bad feeling away, to punish myself for what I let happen to me, and to get the badness out. For other people, it was to ground them in reality, to connect them with reality. When I feel numb or go to the place where I disconnect from reality, I need to feel pain to bring me back to the here and now. Nothing else will ground me. The pain makes me realize that I am really here. And for others, expressing their feelings. It's a way of expressing negative feelings about myself that build up inside in me. As someone who finds it difficult to put things into words, it can at times be the only way of expressing how I am feeling. So given that self-harm is as common as it is and is increasing in frequency, an account of the very strong link between self-harm and those that end their life by suicide. How do we identify risks for suicide? In general, we are very bad at predicting risks. Very bad at clinical level, and very bad even at an individual, at a home and a school and a public level. There have been many, many studies done on trying to predict risk. And a meta-analysis is where you look to all the literature that has been written, all the studies that have been conducted with regard to predicting risk of future suicide following self-harm or other risk factors. And individuals have tried to set a high-risk group by putting in certain risk factors into that and also identifying a lower-risk group. And yes, it's true that when you put somebody in a high-risk group, that they were 5 times more likely to have ended their life over a period of time than those that ended up being categorized as low risk. However, about half of all suicides were as likely to occur in the lower risk group. And in fact, 95% of patients that had been allocated to the high risk category did not die by suicide. So this is a slightly old meta-analysis that was done in 2016. Recent evidence doesn't result in any better results. In our own study here in Crumlin, where we looked at the clinician judgment of identifying risk based on the presentation of young people, we were unable to predict which children may have represented to the hospital with further self-harm over a 10-year period. So some researchers and clinicians have wondered, well, maybe we are not using the best scales to help identify risk. And so is there a better scale out there that might help us? And again, a cluster of different studies have been put together in a systematic review, looking at 7 different scales, and none of them have sufficient evidence to support their use in clinical practice. And in fact, alarmingly, they may provide false reassurance and therefore be potentially dangerous. As one clinician researcher wrote, we may well be putting our own professional anxieties above the need of service users or our patients, and paradoxically increasing the risk of suicide following self-harm by misattributing levels of risk to one group over another group. So suicide prevention is more a social than a medical issue. And society can help, and certainly has helped, by restricting access to means of suicide, restricting guns, protecting iconic locations like the San Francisco Bridge, and also ridding or reducing access to dangerous medications or poisonous substances. The role of mental health services, however, is to treat mental illness and alleviate the pain of patients and families, rather than expending energy and resources on futile efforts of risk assessments. And if the mental health clinicians and those they serve can absorb this reality, they will be much better placed to understand and help those struggling with the urge to end it all. Our job as mental health clinicians is to conduct a thorough and therapeutic assessment of all presentations of self-harm that come before us, taking all of them seriously and non-judgmentally, and to try and identify individuals that have treatable mental illnesses and move them towards services that allow engagement with that. And for other individuals where there are other stressors, to try and help them develop better coping strategies and resolve those triggers. So how do we do this following presentation or an awareness of self-harm? So if somebody presents, we offer a holistic assessment looking at individual factors, looking at family factors, looking at medical and developmental factors, and looking at environmental factors. And I refer to this as the if-me model. If it was me that was going to a psychiatrist, how would I like them to assess me, and how would I like them to plan treatment interventions? I wouldn't want it to be a narrow medical focus. I would want it to be much more holistic. So when it comes to self-harm presentation, the first thing is to assess the self-harm itself, what method was used, whether it was associated with suicidal intent or not, what degree of lethality existed, because that's going to dictate whether they need to urgently go to a hospital, or whether, if I'm working in a community setting, whether primary care or specialist mental health services, whether I'm able to manage the young person there. Very importantly, among children and adolescents, is to establish what their expectation was about lethality. A young person might think that 20 paracetamol is a very safe thing to take, because after all, it's freely available or readily available, and many people take it just for headaches. Whereas they may think that taking 3 tablets of a parent's antidepressant medication is very serious and may kill them. And if therefore we as clinicians give more focus on the young person who took the 3 tablets, because we know it's not lethal and SSRIs are generally very safe in overdose, we might miss the fact that the young person actually thought they had taken a lethal dose. Also, we need to establish whether the young person has access to lethal means, such as tablets at home that might have been stockpiled, or weapons that might be existing in the family. We want to find out, after the young person engaged in the self-harm, what did they do after that? Did they immediately regret it and tell a parent or somebody and seek help? Or did they not disclose it to anybody until perhaps physical symptoms emerged and they were noted by a school teacher or by a family member? We want to know about their current thoughts at the time of assessment, whether they still had thoughts about wanting to end their life, or indeed whether they had any plans to do so. We want to know about what their intent is about going forward, whether they have remorse or regret for the act, how and what do they see as their reasons for living, and whether they are future orientated. Because if somebody is thinking about the summer, for example, that gives us some reassurance that they're not immediately planning on ending their life post-assessment or perhaps post-discharge. We want to look for evidence of hopelessness, because that drives self-harming behaviour and has been recognised as a particular risk factor. We want to look for impulsivity, such as in ADHD, because again, we know that already from the thought of thinking about self-harm to the act occurs in less than an hour. So those children and young people will be more at risk. We also want to know if they're engaged in taking other substances, because that might reduce their inhibition, such as alcohol or substance misuse. And we inquire about thoughts, intentions of other violence. Very importantly, in our assessment, we will look for any psychiatric disorder, especially a mood disorder, which is often associated with futility feelings or feelings of sadness or depression or hopelessness. We will look for schizophrenia, substance misuse, anxiety, and personality disorders. We will ask about previous psychiatric diagnoses and how they have been treated. And most importantly, again, on account of its predictive risk, we will ask about whether they have ever engaged in previous episodes of self-harm or suicidal ideation. And we will also ask about family history of same, because we know that genetically there is a slightly higher risk of young people engaging in self-harm, suicidal ideation, and completed suicide if a family member has also engaged in that. And this occurs not just on account of modelling, but also occurs in genetically monozygotic twins that have been reared apart from their parent. So it suggests that there's a genetic vulnerability. We inquire about medical diagnosis, because certainly among the older age group, having a medical illness is one of the highest risk factors for ending one's life by suicide. And we look for developmental vulnerability. In terms of family and psychosocial situations, we want to assess, are there any crises or chronic stressors, whether there is family or parental discord at home, or whether there is peer difficulties, including bullying. We ask about past or current abuse or neglect, and we ask about their education, particularly with regard to academic struggles and what their living situation is right. By asking about all of these, we are trying to develop both a very individualistic assessment, but also an individualistic treatment approach that is going to recognize both strengths and weaknesses for the young person and their family. Asking about culture or religious beliefs or peer beliefs will be helpful on account of the fact that religious beliefs may be protective from suicide and peer beliefs may actually increase a risk of contagion. We ask about the extent and the nature of their support network. Some of the individual strengths and weaknesses include IQ and academic abilities, the young person's habitual coping style, whether they believe they have an inner locus of control and agency, or whether they believe that everything that happens to them is outside or external to their control. Certain personality traits, including optimism and pessimism, the capacity for reality testing, and the fact that they would realize that following suicidal attempt, the reality may be death, which is permanent. And we establish the ability of the young person to tolerate psychological pain and satisfy their psychological needs. These allow for bespoke planning of the risk factors and the protective factors. Protective factors particularly include strong relationship with trusted others, whether it's a sibling, a family member, a school member, or a peer. Positive peer connections, problem-solving skills, access to mental health support, and emotional literacy. That means the ability to identify their own emotions and to be able to communicate those to others, but also identifying the emotions in other people and being able to communicate that to the other person. That is often referred to as emotional intelligence. And unlike innate intelligence, emotional intelligence can be taught. And so sometimes part of our treatment will be working very much with developing and optimizing emotional literacy. So for parents, the signs to maybe look out for at home are unexplained injuries, or maybe the young person wearing long sleeves in warm weather, trying to hide their arms or legs, maybe becoming emotionally withdrawal or sudden changes in their mood. Or you've noticed that sharp objects or tablets have gone missing. And maybe noticing their social media content has been linked with self-harming. When to seek help, whether it's professional or whether it's from your GP or whether it's from the emergency department or mental health specialist services. When self-harm is severe or escalating, when you believe or you are worried there is a risk of ending their life by self-harm, if there is an underlying mental health condition, or if as a parent your own instincts say that something is wrong, never doubt yourself and never be worried that your presentation to a clinician will be seen as the wrong thing to do. Your initial help seeking may start with your GP, with school, or with the community child and adolescent services, and if out of hours, the emergency department. So some of the do's. Stay calm. Obviously, easier said than done, and it's natural to feel a lot of emotions, scary emotions, but try as best you can to approach the conversation in a calm and non-judgmental way. Your reaction can significantly impact whether your teen or young person feels safe opening up to you. Listen more than you talk. Create a safe space where your teen feels heard and let them express their feelings and experiences without interruption or immediately jumping in with solutions. Express your concern and care and validate their feelings. Let them know you're worried about them and that you just want to understand and to help. And acknowledge that their pain is real, even if you don't fully understand it. Avoid minimizing their emotions or telling them not to feel a certain way. And you can say things like, it sounds like you're going through a really tough time. Do you want to tell me about it so I can understand better? Ask open-ended questions, encouraging them to share more. So asking questions like, what has been making things difficult for you? Or how does self-harm help you cope? Encourage healthy coping strategies, like positive alternatives, exercise, journaling, creative expression, talking to a trusted friend, or relaxation techniques. And there's a biological basis to why all of these are helpful. These stimulate the dopamine and the serotonergic system in our central nervous system, and that optimizes or improves our mood. Seek professional help. Encourage your young person to talk to a mental health profession. Offer to help them find someone and go with them to the appointments if they're comfortable with that. Fostering open communication, creating an environment where they feel safe to talk about anything, even difficult emotions or urges to self-harm, or indeed even behaviors you prefer they weren't doing, like drinking or being involved with romantic partners at an age that you would otherwise have thought was too young. Allow them talk without fear of judgment. It's better you know about those risks and you're able to help them reflect on why such behaviors may pose a threat to them. Regularly check in with them, not just about their self-harm or not just in response to self-harm, but at other times during the day and during the evening. Be patient and understanding. Recovery is not linear and there may well be setbacks, so continue to offer support and understanding at difficult times. And again, easier said than done, but try and avoid showing frustration or impatience. Active listening means when your child is talking to you, you give them your full attention. So put aside distractions, sit down, make eye contact with them, and really listen to what they're saying, both verbally and non-verbally. If they happen to talk to you when you're cooking the dinner and you have to get on with that, or maybe when you're driving the car, and if you feel unable to give them your full attention, either stop what you're doing if that's possible, or suggest another time as soon as you can so that you can bring up the conversation again. Help them identify triggers and maybe work with their therapist if they have one, such as situations or emotions or various thoughts that they might have that will trigger their self-harm urges. Because once you've identified these, you can work together on strategies for either managing them or seeking out additional support when they need it. Support the development of more adaptive coping skills and help them practice these on a regular basis. As mentioned, they may include mindfulness exercising, relaxation techniques, breathing techniques, physical activity, going for a walk or a run, and it's been recognized that this is better in green spaces than in the cities, or creative outlets, hobbies. Reduce access to self-harm by reducing access to harmful products at home. This is very important, but obviously there's a limit to what you can do to make your home safe. Certainly, you can remove all tablets and medications and keep them under lock and key. You can remove access to dangerous objects like guns or axes or saws if they are about. It is difficult to remove all access from knives like kitchen knives or pencil sharpeners because a youth will be able to find any object to self-harm. They may walk out and get plastic that's part of food packaging and cut that and use it to self-harm. So the job is to be aware of potential risks and as best you can remove access to the more dangerous. Involving the family. Depending on the family dynamics and your own child's comfort level, involving siblings or other supportive family members in a positive and understanding way can be helpful. However, ensure that your child feels in control of who knows and what they know. You, as a parent, may wish to be actively involved in the therapy, and that is the best scenario when your child is willing for that to happen. So try and make time to attend their therapy with them, even if the agreement is you sit outside for most of it, and at the end of the session, the therapist will reflect with you for 5 minutes and give you an update as to how the young person is doing. Excuse me. And this will certainly help you support your teen at home because the therapist may give you some specific examples. With your child's consent, maintain open communications with the therapist, with the school counsellor, or with other professionals that are involved in their care. Exploring medication options. If it's recommended by a psychiatrist, be open to discussing medication options with your children and support them in taking medication as prescribed if it has been prescribed, and attend follow-up appointments. Also, be careful about how much medication your child has access to and whether, in fact, your child is at a state where they are able to take their own medication every morning with or without supervision, or whether that is something that you feel is better controlled and regulated by yourself. Excuse me. Because self-harm occurs usually with other mental health conditions like depression or anxiety, or with eating disorders, make sure that these are also being addressed by the professionals, because there is evidence-based and effective treatment out there. And if they are not addressed, your child's self-harm may get worse. It's very important to take care of yourself as a parent. So you may be able to do this by seeking help from your friends, but you may also need to seek therapeutic support yourself from support groups or from specialist services. Taking care of your own mental health will enable you to be better able to support your teen. Educate yourself further, both about self-harm, but also about mental health and what sort of effective parenting strategies are out there. Understanding the complexities of self-harm will help you respond with empathy and knowledge. Set realistic expectations. Understand that recovery takes time and effort, and avoid putting pressure on your teen to stop immediately the self-harming, as this may be counterproductive. Remember, they have been using it as an adaptive coping strategy to deal with maybe other very difficult emotions. And although it is maladaptive, you need to have given the teen the skill set for other adaptive coping strategies before they're able to eliminate it completely. So focus on progress, not perfection. And practice self-compassion. It's natural to feel worried, scared, or even guilty. So be kind to yourself and remember, you are doing your very best to help your child. Be an advocate for your teen in getting them the support they need, whether it's through school resources academically, whether it's through mental health services or other community programs. And certainly we are only too aware how much parents do advocate when we meet them in clinical scenarios, but also how difficult it is on account of the dearth and the under-resourcing of child mental health services in general, particularly access to out-of-hour services. So these are some of the don'ts, if you can. Don't panic or overreact, because it can scare your young person and make them shut down and be less likely to talk to you. Don't be judgmental, critical, or blaming, because that may make your young person feel ashamed or guilty or misunderstood. And believe it or not, they often already do feel quite ashamed and guilty. They didn't want to engage in self-harm, but found that that was a method that had become adaptive to them. Don't assume you know why they're self-harming, or don't assume they're doing it for attention. In a way, they may be trying to draw attention to the negative feelings and the struggles they're having, and they may have no other way, as one of the young people said, to express these feelings other than their self-harm. Don't dismiss their feelings by saying it's no big deal or you'll get over it. Don't threaten or punish them. This will likely make the behavior worse and damage the relationship between you. And don't focus solely on stopping the self-harm. While safety is, of course, important, focusing only on the behavior without addressing the underlying issues is not effective in the long term. Don't show extreme distress or guilt. It's okay to express your feelings, that you do feel very sad and maybe you do feel guilty because you didn't do something or you weren't there for them. But overwhelming your teen with your distress can make them feel responsible for your emotions, and they may be unable to cope with it and further feel ashamed and guilty. Don't promise secrecy if it involves safety. So let your teen know that while you respect their privacy, you may need to involve other trusted adults if their safety is at risk. So this might be, for example, if a mother finds out their child is self-harming, the child may not wish to tell their father, particularly if mother and father have been separated. However, if the young person is spending time with the father would need to know that in order for them to be able to provide that safety, supportive setting. Don't compare your child's situations to others, because everybody's struggles are unique and comparisons can be invalidating. Don't offer simplistic solutions because self-harm is complex. Don't ignore it or hope that it will go away. Self-harm is a sign of distress and it does need to be addressed. It may not need professional support, but it needs acknowledgement, validation, and an open discussion with you so that you can move your child towards more adaptive coping. Remember, creating a safe, supportive, and understanding environment is crucial for helping a teen who is struggling with self-harm. And your willingness to listen and to seek help together can make a significant difference. Ending with the myths and the facts, it is a myth that they're just doing it for attention. If I talk about it, it will make it worse. Only girls self-harm. These are myths and they need to be challenged. Some useful resources to you. In Ireland, Jigsaw, Pieta House, specialist mental health services like community child and adolescent mental health services, self-injury support organisations, Young Minds, many books and podcasts, including webinars such as this that you're listening to. And there are support groups organised specifically for parents. I want to thank you very much for your attention. And I want to express sincerely to you the fact that self-harm is something that we would never say should not present to a service. It also is something that we are grateful when you allow us to help you with your young person identify what are the underlying struggles and to help you with them develop more adaptive coping strategies. I want to thank the organisation Cycle Against Suicide for the webinar series that are providing to you in conjunction with the Department of Child and Adolescent Psychiatry at UCD. Thank you.